Hello everyone. Thank you for being here today. My name is Saniya Chitadze, and today I will be presenting my Doctor of Nursing Practice scholarly project titled Improving Identification of Adults at Risk for Prediabetes through Implementation of the CDC Prediabetes Risk Test. I would like to thank my committee members, Dr. Lisa Strohr and Dr. Richter, for their guidance and support throughout this project. Today, I will discuss the clinical problem, why this project was needed, the evidence supporting the intervention, the project's design, methods, results, limitations, and implications for practice, as well as conclusions. Purpose and aim. The primary purpose of this quality improvement project was to determine whether implementing the CDC prediabetes risk test could improve the identification of adults who were at risk for prediabetes. There were three major objectives associated with this purpose. The first one was to increase identification of patients at risk. Before implementation of this project, the clinic did not have a standardized process for identifying these individuals. The second objective was to improve opportunities for early hemoglobin A1C testing. Identifying risk is important, but identification alone does not improve outcomes. Once a patient is recognized as being at high risk, providers can determine whether additional laboratory evaluation is appropriate. Finally, the third objective was to increase opportunities for preventative interventions and referrals. Patients identified earlier can receive counseling related to nutrition, physical activity, weight management, and other modifiable risk factors. The larger goal was to, therefore, not to simply administer another screening questionnaire. It was to create a pathway from risk recognition to meaningful clinical action. Here I've attached an illustration that shows normal, pre-diabetic, and diabetic percentages of hemoglobin A1C. Unfortunately, at 6.5, the patient's already diabetic, and between 5.7 to 6.4 is when they're considered pre-diabetic. Anything below 5.7 is normal. Why this project? The need for this project becomes clear when we look into the burden of prediabetes in this country. In the United States, nearly 98 million American adults are estimated to have prediabetes, and more than 80% are unaware that they have it. That means a very large number of patients may already be at risk for developing type 2 diabetes without even realizing it. This is especially concerning because progression from prediabetes to type 2 diabetes is not inevitable. There's an important period of opportunity where preventative interventions may delay or potentially prevent that progression. However, healthcare professionals cannot intervene early if patients at risk are not identified. Within the clinical settings or the setting where the project was implemented, there was no standardized prediabetes screening process. Screening could therefore vary depending on the individual provider, patient's presentation, existing diagnoses, whether laboratory testing happened to reveal an abnormal result. That created a clear practice gap. The question became, could we take something that is already evidence-based, simple, and readily available and integrate it into routine care to make identification more consistent? That question ultimately became the foundation of my DNP project. Review of literature. The literature supported the use of earlier and more standardized approaches to identifying prediabetes. Prediabetes represents an immediate state between normal glucose regulation and diabetes. Because patients may remain asymptomatic during this period, screening becomes particularly important. One of the strongest themes identified in the literature was the growing burden of prediabetes. Approximately 1 in 3 adults in the United States has prediabetes, and the majority remain unaware of their condition. Another important theme involved lifestyle intervention. Evidence demonstrates that interventions such as weight reduction, increased physical activity, and dietary modification can significantly reduce the risk of progression to type 2 diabetes. Lifestyle intervention has been associated with reductions in progression of up to approximately 58% in the appropriate population. The literature also supported that CDC prediabetes risk test is a practical screening approach. It's quick, it's free, it's evidence-based, relatively easy to incorporate into clinical practice. Importantly, it does not require specialized equipment to identify who may warrant further evaluation. Another consistent issue identified in the literature was variability in the screening. When screening depends primarily on individual clinical judgment, some patients who meet risk criteria may not be recognized. Current clinical recommendations also support screening adults who are at risk for abnormal glucose metabolism. Taken together, the evidence suggested that a standardized screening process could help close the gap between the existing recommendations and what occurs during everyday clinical practice. Theoretical framework. The theoretical framework used to guide this quality improvement project was the Plan, Do, Study, Act, or the PDSA model. I selected this model because it provides a practical framework for introducing a clinical change, evaluating its effectiveness, and then refining the process based on the results. During the plan phase, the existing workflow was evaluated and a standardized screening algorithm was developed. This included determining CDC risk tests would be administered, how and when it would be administered, who would administer it, and what would happen when a patient screened as high risk. During the do phase, staff education was completed and the new workflow was implemented in clinical practice. The study phase involved evaluating the data collected during implementation. I examined screening completion and compared identification before and after implementation to determine whether the intervention produced a measurable change. Finally, the ACT phase involved considering how the process could be refined and sustained. One reason the PDSA worked well for my project is that the quality improvement does not necessarily require a complicated intervention. Sometimes meaningful improvement comes from examining an existing workflow, identifying where opportunities were being missed, and making a focused change that staff can realistically sustain in the future. Methods and design. This project used a quantitative quality improvement approach with a quasi-experimental pre- and post-implementation design. The implementation model lasted 10 weeks from January to March and was guided by the PDSA framework. The intervention involved several connected components. The first component was staff education. This was important because successful implementation depended on everyone understanding not how to use the screening tool, but also why this change was being made. The next step involved administration of the CDC prediabetes test. Patients who were identified as being at high risk could then move forward in the clinical pathway, which included provider review and the point-of-care hemoglobin A1C testing when appropriate. From there, the process included patient education and lifestyle referrals. This sequence was intentional. Screening was not designed to exist as an isolated task. It was incorporated into a larger preventative care workflow. The designed final product was easier identification, improved patient outcomes, a more standardized workflow, and a greater consistency with evidence-based care. From a quality improvement perspective, feasibility was also extremely important. An intervention may be evidence-based, but if it creates a major burden for clinical staff, long-term sustainability becomes difficult. Therefore, this project emphasized integration into the existing workflow. Intervention. This slide shows how the intervention functioned during annual wellness visits. The process began with medical assistant. During the patient visit, the medical assistants administered the CDC prediabetes risk test during the triage phase. The completed screening information was then available for provider review. If the patient's result indicated increased risk, the provider could evaluate whether point-of-care hemoglobin A1C testing was appropriate. This was followed by patient education. This part of the process was especially important because receiving a risk score without understanding it means what it means has limited value. I also attached the CDC's risk test here in the slide. There are 7 questions. It's a very simple questionnaire. First one asks about the age, then it asks about the gender. If you're a woman, have you ever been diagnosed with gestational diabetes? That's question number 3. And then, do you have a family history of diabetes? Number 5 is if you've ever been diagnosed with high blood pressure, because that's also been linked to diabetes. And are you physically active? And the last question is, what is your weight category? If the patient scores 5 or higher, that means the risk test questionnaire is positive, and then the provider would move into the hemoglobin A1C testing to support this. I also want to add here for slide number 8, sample. Now looking at the project sample, there were 301 eligible patients during the implementation period. Of those 301 patients, 287 completed the screening process. This represents a completion rate of 95.3%. I believe this is an important finding beyond the primary outcome because it provides information about feasibility. A screening process cannot improve identification if patients are not actually completing it. Achieving a completion rate greater than 95% really suggests that the screening process could be incorporated into routine visits without creating a major burden or barrier. The clinical practice itself had approximately 2,654 active patients. Although the project sample represented only a portion of that population because I only followed one physician and only his patients, the high completion rate provides support for considering broader implementation. It is also important to recognize that quality improvement projects occur in real clinical environments. Patients arrive late, appointments change, workflow becomes busy, and staff members have completing responsibilities. Therefore, obtaining 287 completed screenings out of 301 eligible patients was a meaningful indicator that the intervention was practical within this particular setting. Data analysis. The next step was determining whether the intervention actually changed identification. Data were collected on the number of eligible patients and the number of completed screenings. The primary analysis compared identification before implementation with identification following implementation. A 2-proportion z-test was used to determine whether the difference between the pre and the post-implementation proportions was statistically significant. The alpha level was established at 0.05 and a 95% confidence interval was used. Statistical testing was important because simply observing that the numbers increased would not be strong enough to determine whether the change was likely meaningful. At the same time, I also considered clinical significance. In quality improvement, a result can be statistically significant without necessarily producing an important change in practice. Therefore, I wanted to evaluate not only whether identification increased mathematically, but also whether the size of the increase represented a meaningful improvement in the clinic's ability to recognize patients at risk. As the next slide demonstrates, the difference was substantial. Here is my results slide. This was a central finding of the project. Following implementation of standardized screening, identification of patients at risk for prediabetes increased by 26.8 percentage points. The statistical analysis produced a z-score of 7.74 with a p-value of less than 0.001. Because this p-value was substantially below the predetermined alpha level of 0.05, the finding was statistically significant. In practical terms, the results suggest that the increased identification was unlikely to be explained by random variation alone. However, the clinical meaning is even more important. The intervention did not involve an expensive diagnostic device, a new medication, or a complicated clinical program. The primary change was introducing a standardized, evidence-based screening process into routine care. For me, this was one of the most significant lessons from this project. Sometimes patients are not missed because healthcare providers lack knowledge or because appropriate interventions do not exist. They may be missed because the clinical system does not consistently create an opportunity to identify them. Standardization helped create that opportunity. Every additional patient identified represents someone who may now or have earlier opportunity for further evaluation, counseling, lifestyle modification, or referral before progression to type 2 diabetes. For this slide, limitations. Although the results were encouraging, several limitations must be considered when interpreting the findings. First, the project involved a relatively small sample and was conducted in a single clinical practice. Because of this, the findings cannot automatically be generalized to every primary care setting. Different clinics have different patient populations, staffing structures, resources, and workflows. Another limitation was the short duration of the project. The implementation period was only 10 weeks, which was sufficient to evaluate whether screening improved identification, but not long enough to evaluate long-term sustainability. There was also no long-term patient follow-up. For example, this project did not determine whether patients who were identified as high risk subsequently lost weight, increased physical activity, improved their hemoglobin A1C, or avoided progression to type 2 diabetes. Patient outcomes were not primary outcomes of the project. The focus was specifically on improving identification. These limitations provide important directions for future work. A larger study across multiple clinical sites with longer follow-ups could help determine whether improved identification ultimately translates into measurable long-term health outcomes. For discussion, returning to the original project question, did implementation of the standardized screening process improve identification? The answer is absolutely yes. The findings demonstrated that an evidence-based screening process significantly increased recognition of adults at risk for prediabetes. This matters because earlier recognition creates an opportunity for earlier intervention. Another important finding was that the workflow appeared feasible with routine clinical practice. The high screening completion rates supported this observation. Staff education also contributed to consistency. Instead of screening depending solely on individual provider judgment, the process became part of the defined workflow. The project therefore assessed more than one issue. It increased identification but also created a more consistent approach to preventative care. For patients, earlier identification meant earlier opportunities for counseling, referral to preventative resources. For providers, standardized screening provided additional information that could support clinical decision making. And for the practice, the intervention demonstrated that evidence-based change does not always have to be expensive or technologically complex. A simple screening process, when thoughtfully integrated into the workflow, can make meaningful difference. Implications for practice. The implications of this project can be considered at 3 levels: clinical practice, patients, and healthcare community. At the clinical practice level, standardized screening improves consistency. Instead of relying exclusively on whether an individual provider remembers to assess risk during a busy visit, screening becomes part of routine care. It also supports evidence-based decision-making by providing clinicians with a structured method for identifying patients who may benefit from additional evaluation. For patients, the most important implication is earlier recognition, timely lifestyle counseling and intervention, increased opportunity to delay or prevent type 2 diabetes. And for healthcare communities, supporting preventative care initiatives and population health, demonstrating a feasible low-cost quality improvement strategy, and providing a model that can be replicated in other primary care settings. In conclusions, the project demonstrated that standardized prediabetes risk screening could be successfully implemented into routine clinical practice. For future directions, could include expanding implementation to additional clinical settings, monitoring patients over longer periods, evaluating whether early identification leads to measurable changes in hemoglobin A1C, lifestyle behaviors, and progression to type 2 diabetes. Impact. Earlier identification supported timely intervention, improved delivery of evidence-based preventative care, and demonstrated practical quality improvement strategy. And for the DNP journey, the DNP role involves not only caring for individual patients, but also recognizing opportunities to improve the systems in which the care is delivered. My biggest takeaway from this project is reflected in the statement on the slide. Evidence-based practice begins with small, sustainable changes that improve patient outcomes. In this case, that change was simply creating a consistent opportunity to ask, is this patient at risk? By asking that question earlier and more consistently, we created an opportunity to intervene earlier as well. Thank you all for your time and attention. I appreciate the opportunity to share my doctorate project, scholarly project, and I am happy to answer any questions that you may have. These are my references. Thank you all for attention.